So Rainer Sauerborn from Heidelberg, using ongoing decade-long health cohorts from Africa and Asia to quantify health impact of climate change. A big title, a long title.
Thank you very much for inviting me. I have become bilingual because I'm enjoying a sabbatical here in the Centre Virchow-Villermé, which is a joint venture between the Charité in Berlin, although I'm from Heidelberg, and Sorbonne Paris-Cité. So half of the room is my colleagues now by this collaboration. So many of you talked about mosquitoes, about worms, and let me now talk about the problems of measuring health at the population level in countries where there are no good data. And Cyril, you mentioned that. Health services produce very bad data, better not to look at them. So what do? That's where the largest health impact will be. Shall we just look where the good data are? Shall we look at heat waves in Göteborg here and in Paris, or shall we look at where the real problems are? And many people say, oh, you don't have data, you can't do it. I would say there are data, we just have to make use of them. Let's see. Oh, this goes like this. If we could dream up a perfect data set, we would have time series, as many of you, time and spatial series, on deaths by cause, age, sex, location, and time. Valid data on the entire population, like they have in Sweden, for example. Then you would have the same for diseases. Death is easy to measure, of course. It's pretty there's no doubt about the fact of a death, and people remember, but a disease, what is a disease, and whether you remember it, that's another issue. But in a perfect world, we would have that too. Then we would have a time series from meteorology, temperature, we've seen many of them, but for the same population. Very often, these time series are in another place, and you have health data from a different place. So you can do either on-site measurement, they are not expensive, not as bad as, where's our colleague from the UV? Here. They are pretty good. Okay, I mean, temperature and rainfall is pretty good. Or you can get remodeled data for every point on the Earth. You can get remodeled data for every hour since the last 20, 30 years. So that shouldn't be the problem. And then you need other time series. We've heard so much about the exposome. You need data from agriculture, from water cycle, and so forth. So that would be my wish list if I could dream up the perfect data collection. Is there such a thing? Now, everybody has said this, the validity of routine reported health data is really lousy. I've been a district medical officer in one of these district hospitals, and I can testify that you shouldn't look at them from an epidemiological angle, maybe for resource planning and so forth, because 1 in 5 people who are sick go there, and there's a heavy economic filter. So who comes to the health services is not representative of the population. So better not look at them, at these data. Of course, you should look at the people who come there. So they're incomplete. Some months are missing, and probably the most important month. So these facility-based data, you can't use them. That means also WHO data. For those who are from WHO, I'm sorry, but they just compile and report, and what you read in the wonderful glossy reports is not true in the sense of statistic. And you cannot do a comprehensive health measure. Do you know this story of QALYs, DALYs, years of life lost? If we do climate and health research, we must aggregate. Otherwise, we have 59 numbers of prevalent cases of this, numbers of incident cases of this, and you don't get the picture because the politicians want to know in December how many deaths are due to climate change, and they don't want to go into any detail on which disease causes what. So we need to have some overarching comprehensive health measure. And then we can't follow, in the current data sets, we can't follow longitudinally. We just have report on this year. So I think I don't have to convince you that we need another source of information. And before I show my stack of cards to you, let me show you this slide. Maybe you've known it already from the late Tony McMichael. He says, look, climate change is a matter of decades. Your research funding is 3 years. And how do you do this? How can you stand up and say, I will do research in climate change and health, or climate change and this? And he said, well, you can learn from the past. Climate, yes, is decades, but there are decade-long data sets on health. but also meteorology. You can get satellite data the last 3 decades. So let's look at the decades past and see what the climate signal was there. We have 30 years of health data, as I will show you, which is already under climate change. And then look at the present, all these detectors, and measure their presence very carefully and do some projections, and then talk to the climate people. How can you use this kind of runway before it takes off into the future? And the climate modelers I have talked to, they told me it's great if you have 20 or 30 years of dose response data on which we can build now a projection of health into the future based on our climate models. So that's the big picture. And now this is the type of cohorts, and there are 60 million people in Africa and Asia, in very poor countries, under this set of standardized surveillance. They call it Health and Demographic Surveillance System, HDSS. What it is a dynamic cohort, which was assembled, let's say, for the case of Matlab. I think you showed Matlab, 62, if I'm not mistaken. So 53 years of observation in the same standardized Johns Hopkins supervised way. And it's a dynamic cohort, so basically demography, you come in by birth or by migration, you go out by death or by migration. It's as complicated as that. And here you have a dynamic population which is updated. You have a denominator. How many of you have ever done a research where you knew what your denominator was? Very, very few of us. We do phone surveys, we do sampling. Very, very rarely we have an exact idea about the denominator on which we do our research, from which we sample. Okay, so this is and now we add morbidity. And how we do this is part of my talk. This is Matlab, this is what you can do. 1974, they could have added 12 more years, and you see the change from these are non-communicable diseases, and these are infectious diseases, and these are injuries. You see this enormous you wouldn't think that in Bangladesh, 75% of deaths are due to NCDs, and not to diarrhea, not to pneumonia, and so forth. Anyways, that is the kind of good data that you get. And here are the about 35 sites. Yellow is in Asia, from Thailand, Indonesia, Papua New Guinea, India, of course, Bangladesh, and most of them are from Africa. And here's where the oldest starts. One is, by the way, from France, I have to say. Many are funded by France. And Pizon and company, Gilles Pizon, in Senegal. Yeah. He has started at the same time as, I think this is it, a little bit later, one of the first in Africa, the first in Africa. So 2006, I should sort of update this graph. So we have an enormous decade-long data set from so many countries, from all climates, all biosphere, from the highlands of Ethiopia to the coasts of Bangladesh. And that's the perfect storm for doing climate change and health research, if you only had the good health data. Here is where I have been working for a while. This is Burkina Faso, and we started in 92, and now we have roughly 30 years data. And I show you data from this site in Burkina Faso. Here they are, and you can do lots of things. You can do randomized controlled trials with this. You can do meteorological information, the clinical cohorts, qualitative studies, household surveys nested in them. It's just the platform that you can use for all sorts of studies. And I said here, 30 cohorts times roughly 100,000. It's a contiguous population, by the way. It's not sampled. Usually it's a district. Plus 20 years of average observation, 60 million person years. I mean, if the quality is good, then we have really a perfect storm here to do research in countries. And this is the kind of data that Selmi showed. The speaker after you is not listening for the moment. So you see the data, this is a time series of years of life lost based on 7,425 deaths from all causes in 10 years. And you see the usual, how often have we seen a U-shape? From which countries have we seen them? Well, Thailand and was in it, but not from Niger. So you can do it, and most of these sites are in the neglected countries. And you see exactly that's the result, 1% increase in temperature above 30 degrees associated with a 2.4% increase in all cause. Now we're doing detailed ones, malaria and non-communicable and so forth. So we see what we knew from Stockholm and from many other sites, also from this. And that's just to show you that the data are good. They are in line with what we would have expected. The second step, so that's death. Death is always an easy thing to measure, but it's not the entire health impact. We want people not to fall ill, so what do? We have added, since 15 years, a household panel survey on 10% of that demographic surveillance population, and have asked them, have you fallen ill? What have you done? How did you call the disease? Have you had diarrhea? Have you had this? So to get as close as we could get from reported diseases in a survey to morbidity. And now I can't go in any detail, but I'm happy to discuss this afterwards. Now we try to mix this with the death and vital event reporting in such a way that we only have to have one stop in each household 3 times a year. And in 10% of the times, by computer generated, all this is now done with tablets and so forth, the interviewer knows this household has to get the morbidity questionnaire. And then we have gotten rid of this problem. Here you have a household, and here they fall ill. Beginning, short disease, here's a chronic disease, here's the year, by the way. And so if you come in only in here, you miss a lot of diseases, and diseases are wildly seasonal. You wouldn't get, for example, measles in August. So if you only come in August, you'd say there's no measles. So we get rid of this by having also a time sample. So these 10% of morbidity are time sampled. Another 3 minutes, I'm sorry. So we have every month in the same representation in the sample. So I think this is now the blueprint for the entire network to have a comprehensive indicator for morbidity and mortality. So you can do DALIs and you can do, well, I won't get into this. Third step, add time series from meteorology. We do have 10, and this is the area here, this is the Mali border, and we do have 10 meteorological basic stations here. This is precipitation and this is temperature. But now we realize we wouldn't have needed it because we can import the data from the internet. But we still see very interesting local changes from one village to the other. But that's, so you can do it, but you don't have to do it. And this is the dream, of course, where we are not yet. These are colonial French data on temperature. They measured very carefully. And this is now the time we measured, and that's we hand over to the models here, and we see for Nuna in a downscale model, that's another problem. You have to downscale everything to the same scale. We see a variety, but basically 2 degrees is the average for this district in which we have the good health data. We have a downscaled climate model. Learn from the past, predict the future, and measure the near and past. And the last thing is add time series from other sources, and here I have to stop my presentation because I had something that you would like, Robert, for the exposome. We tried to figure out what the weather variability in the past 20 years has done to crop yields and what this has done to childhood malnutrition, given that there are zillion and other factors that come in, from soil quality to fertilizer inputs and so forth. So that's the perfect exposome, and maybe you want to join this research because that poses, of course, it's a statistical Bayesian 2-stage modeling, hierarchical. First we model this on this and then this on this, given all the other. It was turned down several times by funding agencies because they thought it's too complex, you can't do it. That's another problem. If you do exposome research, nobody will fund you. Maybe I should call it exposome and say that you have. So my time is up, so this is now, this is just to show that we are using satellites. This is the one village. We have mapped the fields where the people grow millet and sorghum and so forth. So these are now to be seen from satellite imaging, from rapid eye. You see here the fields of these farmers where we know the household, where we know the malnutrition of children. So different levels from the biosphere, weather, soil quality, population health. We try it. We are not yet there. Currently, a Burkinian scientist does the pilot study for this, and the conclusions. This in-depth network, look it up, in-depth, is really, I think some of you may already be collaborating. Matlab is part of this. There are sites in Ghana, in many African countries, and maybe you should try to hook up with them. They have retrospective data. We need to add morbidity. We can do it. Weather data is easy to add, and then, depending on the research question, the data from the other sectors. And with that, I thank you. Sorry if I've been over time. Thank you very much for your attention.